So next is liver abscess. A 56-year-old woman presented to the ED with a 3-day history of fever and chills associated with malaise and right hypochondrial pain, especially on deep inspiration. Examination showed a flushed facies, temperature of 38.5, and she was mildly tender in the right hypochondrium and deep palpation, although Murphy sign was negative. What are the possible differentials? In a woman who is obviously septic and the localization pointing to the right hypochondrium would suggest some form of hepatobiliary sepsis. And the most common is acute cholecystitis, cholangitis, hepatitis, but cholecystitis and cholangitis are ruled out. Apart from doing the blood investigation, I will do a sepsis 6 for her, and then I will start her broad spectrum antibiotics, fluid, pain relief. I will request an ultrasound scan. The urgent bedside ultrasound scan shows a mixed echolalia. This is a buzzword, mixed echolalia in the right of the liver. The gallbladder and biliary tree are otherwise normal. What would be the course of the management? The mixed echo pattern is highly suggestive of a liver abscess. After adequate fluid cessation and starting broad-spectrum antibiotics, the appropriate next step is to obtain the cross-sectional imaging to better define the lesion for treatment planning. So a contrast CT of the liver is the usual first line cross-sectional imaging for this. A contrast CT of the liver has been performed and representative cross-section is shown here. What are the features that would confirm your diagnosis and determine the management plan? So this is a sizable lesion in the right lobe of the liver in segment 7 and 8 of the liver. The lesion has irregular margin and content show a mixture of fluid and gas with a distinct air fluid level and pockets of gas within the fluid space. These features diagnostic liver abscess secondary to gas-forming organisms. Apart from intravenous broad-spectrum antibiotics, there is an urgent need for drainage of the abscess. This can be done under CT or ultrasound-guided drainage at a preferred option. If when not possible, then by surgical drainage. The subsequent management plan would then involve the following: continued antibiotics for 6 to 8 weeks as per microbiology's culture and sensitivity report, and then tracking is another buzzword, tracking of infective and inflammatory markers like CRP and procalcitonin. Continue monitor the adequacy of the pus drainage if it's still through regular imaging and for guided readjustment as needed to target the residual or undrained areas, identifying possible sources of abscess for definitive management. So what are the most likely sources of liver abscess and how would you go about determining this and managing it? So the most likely causes are appendicitis, cholecystitis, inflammation of the colon, diverticulitis, or sometimes colonic tumors can happen. So abdominal ultrasound and CT have ruled out gallstones and appendicitis. To see the luminal pathology or diverticular disease. Once the patient has been recovered, patient will need colonoscopy to rule out the diverticulitis or the colonic tumors. Thank you.